You shouldn't have gone on.
So welcome to everyone who's joining us. We're doing granulomas this morning. And go ahead, Shane, without further ado.
Sort of make out like a palisading portion there.
Imagine that in this chapter, palisading granuloma.
Yes,
So
sir.
first off, the slide looks kind of washed out, right?
Correct.
But is the epidermis super washed out, or is the epidermis kind of okay? Okay, so the epidermis, so it's not just a bad stain, it's that the dermis really is washed out looking, right? Which is part of the pathology that you see here. And so go ahead and tell me about the pattern of your granuloma.
So it's palisading, I guess, since we are talking about washed out.
And the palisading granuloma, is it making circles, is it interstitial, or is it just one solid line
That
there?
arrow looks interstitial, but maybe I was imagining more under the arrow there. It kind of goes in a circle.
Okay. Okay, so you're making that kind of in a circle there, and if you did that, you're leading yourself towards what diagnosis?
GA.
Towards GA. If you look at the process, does it appear patchy and focal, or does it appear to go kind of side to side?
Sort of side to side. Up
And
down.
so top to bottom, side to side is more likely which of the two? Necrobiosis lipoidica. So, you got yourself into a palisaded necrobiotic granuloma differential, which is pretty good. The dermis is kind of really faded looking, which goes more with NLD than with GA, where the changes are more focal. And you correctly said it's more side to side, top to bottom, which is more NLD than GA. But you can always put it together with the clinical. And, because usually the clinical is miles apart. So. The eminent ocular group.
Yeah, it looks like we have some like giant cells down deep there at the
Giant cells. So
junction.
giant cells, when they're put together, form a
Granuloma.
Granuloma, correct. So we have a granulomatous condition.
Yes.
Go ahead.
Um,
And the granuloma is oriented in what direction?
horizontally.
Horizontal. So that raises one possibility,
Mm-hmm.
which is
And I'll hold the D.
so NL hold the D
If they're not
because
diabetic.
they may not be diabetic. Do you see
The collagen in between does not really look good for that.
collagen in between doesn't appear so degenerated? The other thing is, see how your biopsy specimen looks like a mushroom
Mm-hmm.
with a broader top? You never see that in NLD because it's rock hard, so you get a rectangular biopsy specimen.
Mm-hmm.
Whereas when the tissue is normal, not sclerotic, you get this mushroom appearance where it's broader at the top because you squish it down. It catches the dermis but squishes everything else out of the way, so you end up with this mushroom look, which is normal. Sclerotic conditions, you don't get that. So it's a hint that this was not sclerotic. The one I was kind of going for with granulomas parallel to the surface was leprosy, but that rarely gives giant cells. It's histiocyte granulomas, typically in the absence of multinucleated giant cells. Here you have very prominent multinucleated giant cells. You also have a different pattern of granuloma here. So what would this pattern be? Where it's all in between the
This one,
collagen levels.
interstitial.
So you got interstitial, and you have horizontal. So what things are you going to do with this case?
Maybe slap a colloidal iron on there.
Maybe
Maybe
slap a
polarize
colloidal
it.
iron, since we have interstitial, and this did turn out to be granulomannulary.
Mm-hmm.
The other thing is, if you didn't have the interstitial component, you might think of sarcoidosis.
Mhm.
Again, giant cells, not so much in sarcoid.
Those were the things that I was thinking about.
Very good. And the other thing is there are granulomatous drug eruptions that could have been in the differential as well. Okay, not really 100% in this chapter, but not sure why it ended up in this box, but you are an upper year resident, so ready to graduate, so nothing should scare you, right?
So it looks like you had some degeneration of the collagen, sort of deeper.
Yeah, and what kind of, how would you characterize the collagen?
It looks necrobiotic, kind of.
Yeah, or sclerotic and hyalinized. There's no white space between collagen bundles.
Mm-hmm.
And it's all deep. So what
Yes.
would your differential be?
So like maybe like a top of a rheumatoid nodule or deep GA.
So it absolutely could be that you're just seeing the fibrosis on top of a deep GA or rheumatoid nodule. Other thing, you have perivascular lymphoid infiltrate at the periphery of where you have the sclerosis. If you did a CD34 and you had normal CD34 all through there and it totally disappeared down here,
Maybe like a morphia.
like a morphia profunda, could do that. Why that's in this box, do not know. Okay, Christina.
So they are naked granuloma differential.
So they are naked granulomas, meaning they are not surrounded by a mononuclear infiltrate.
So favor sarcoid in this chapter. It's not really doing the infectious.
So sarcoid would absolutely be the most likely, but then you have to think of infectious, and it would polarize it. And with diffraction, it's not showing up super well, but take my word for it. You
There's something in
find,
there.
actually, I think you can start to see it. Like
Very-
right
very
there, see that little bright fragment there? So you have silica in here, so what does that mean?
That's from the foreign body, silica. But you also can still have sarcoid. Can't rule it out.
Exactly, it's still sarcoid. So years ago when I was a resident, they said silica granuloma was a mimic for sarcoid. Unfortunately, lots of those people went on to pulmonary sarcoidosis. So show of hands, who here has not skinned their knee? I don't see a lot of hands, right? So you all have silica in your body. Why are you not all forming silica granulomas? Because the only people who form silica granulomas are those with a tendency to form granulomas, right? So silica granuloma is basically scar sarcoid. The silica is just a nidus around which the sarcoidosis forms. So for all intents and purposes, all silica granulomas should be considered sarcoidosis, and the patient's worked up appropriately. So, it used to be that you absolutely had to polarize because it could just be silica. Well, you still polarize and then you see silica, but it still means sarcoid. The brightly staining, really kind of deep staining areas are fibrin. You can get little bits of fibrin in sarcoidal granulomas. It is more typical, especially with caseous areas, if you cut your hand on a fluorescent light bulb, that you get that kind of granuloma that really can be a mimic for sarcoid. So silica really is sarcoidosis. Which granulomas mimic sarcoidosis with naked granulomas?
Yeah, like it's the perioral, perioral cleanse disease. I know there's like a pink box in your book, but I'm not going to remember all of them. Certain infectious etiologies can totally mimic it.
So infectious granulomas can, especially leprosy. Perioral dermatitis, which can be perioral and genital in children, rosacea, Crohn's, And then through industrial exposures, zirconium and beryllium are the two that give you granulomatous disease that really looks like sarcoidosis but isn't sarcoidosis. Okay. Iris, what do you see here?
So there are granulomas.
There are granulomas. And you can see them there with giant cells. And there's also all of this hyperplasia of the epithelium and these collections of neutrophils. So PEH, pus, and granulomas.
So in looking at kind of the pink V's, I was thinking of, what's the name?
So you're thinking of Verruciform xanthoma with pink V's. That would be an epithelial proliferation with neutrophils and pink V's. Here we have a lot of pseudoepitheliomatous hyperplasia, neutrophil microabscesses, and granulomas, so a little bit different. Anyone want to jump in there?
Like with the pH.
Yeah, exactly. So infection would be your top things. So this was a patient referred in for sarcoidosis. You see this pattern, now you're really thinking infectious. Deep fungal, so PEH with pus. You have, here come big green leafy veggies, halogenoderma, but granulomas uncommon. Chromo, but granulomas you absolutely could get, so chromomycosis would be in there. Blastomycosis would be in there. Granuloma inguinale would be in there. Leash would be in there. Vegetans, not so much with the granulomas. So you're thinking infectious, and you're actually thinking kind of a narrow list of infections, most of them fungal.
Punch biopsy, have see collections of histiocytes up in the upper dermis, and then also kind of.
And the histiocytes, are they in round collections, long collections, interstitial around collagen bundles?
Looks interstitial around collagen bundles.
Looks interstitial around collagen bundles. Okay, so you have interstitial granuloma. And interstitial granulomas, give me a differential of interstitial granulomatous dermatitis.
So, number one is like interstitial GA.
So interstitial GA. Do you know anything else that can cause interstitial granulomatous dermatitis? Well, interstitial granulomatous dermatitis can. So tell me about IGD.
Interstitial granulomatous dermatitis. I'm not as, let's see.
Anyone want to jump in? What does IGD look like?
Cord sign.
So the cord sign, so rope or cord sign, it looks like a worm has crawled under your skin on your thorax. So this big snaking hard cord down your side, similar to what Mondor's disease looks like, where you get the laterothoracic vein thrombosed. Except Mondor's is more linear. This is characteristically more snaky. Really looks kind of like a worm under your skin on your lateral thorax. And the histology looks like interstitial GA. The other one that's in that group is PNGD, Palisaded neutrophilic and granulomatous dermatitis, which can be variably interstitial, palisaded, and neutrophilic, like the name implies. And that's usually someone with an arthritic. They're kind of like, they look like smoldering connective tissue disease, and they get these granulomas. The other important thing about this slide is the patchy lymphoid infiltrate. GA can have very prominent lymphoid infiltrate or very scant lymphoid infiltrate. So it can be either way. Very few lymphs or very dense perivascular lymphs. More of them have few lymphs. But even if you have dense perivascular limbs and interstitial granuloma, that's still okay for GA.
You normally shouldn't see newts, right? Is that how you can distinguish PNG?
PNGD has many more neutrophils, although you can see some neutrophils in GA in the center of the palisaded granuloma. Okay, so Rachel, this one,
Say it's kind of pale staining.
yeah, so this pale staining deposit of some sort, and what's kind of the most telling thing about it is in a chapter on granulomas, there is very little granuloma there.
Close to home.
You know, there's a tiny, tiny little rim of granuloma, which is all the body is able to mount against that big deposit of granular amphiphilic stuff.
So
It's a
could it-
hint that that stuff
Could
is...
it be extracellular lipid?
So it could be extracellular lipid, like in an eruptive xanthoma, but that tends to look crystalline. And this is more granulomatous, or I'm sorry, granular with these little bubble-like spaces between it. So this is, you could see with various injectables, fillers that tend not to produce granulomas, but they tend to be more mucin-y looking. This is actually what triamcinolone looks like injected. And one of the hints is the triamcinolone is actively anti-inflammatory, which is why, despite the fact you have a whole lot of foreign body in there, you're not making much of a granuloma.
Self-cleaning, just like soap.
So that was a little triamcinolone. Let's Okay. Rob, what do you see here?
So, kind of thick sclerotic collagen, kind of a diffuse infiltrate, somewhat horizontally oriented.
It is somewhat horizontally oriented, and I would say it looks kind of top to bottom, side to side,
Right.
with a square non-mushroom biopsy, right?
Right. So,
That's for those
necrobiotic.
online, that's where you can see the non-mushroom square biopsy. Okay.
So, necrobiosis lipoitica.
So NLD I'd probably put at the top of the list. The only thing that's odd for that is what's this intensely staining stuff here?
Is it fibrin?
Fibrin. So what kind of granulomatous conditions have fibrin?
So, like a rheumatoid nodule?
So rheumatoid nodule and deep GA.
Right.
I would then add to the diagnosis. So it's unusually top to bottom, side to side. So definitely GA, or I'm sorry, NLD belongs in the differential. But with the fibrin, you have to consider deep GA rheumatoid nodule, and the clinical that went with that is more of a deep GA.
Doesn't belong in the chapter either.
Looks like Brian is there.
Yeah, so this one looks like you have some palisading granuloma
Palisading granuloma around.
around the deeply staining, probably fibrin in this case.
Yep. If it's deeply staining like that, that can only be fibrin. Nothing else looks like that. And fibrin, by the way, is red. Fibrinogen is blue. So when you look at a vasculitis, if it's an early vasculitis, there's a lot of blue because the fibrinogen hasn't polymerized yet. Late vasculitis, it's red because it's all turned to fibrin. And rheumatoid nodules, it's red because it's very chronic. It's all polymerized fibrin, not blue fibrinogen that just leaked out of a vessel. So if you have palisading granuloma around fibrin,
Yeah, so this one is not as rectangular, so maybe a rheumatoid nodule. might be
yeah,
good for this
rheumatoid
one.
nodules, deep GA, that's your differential. So what is the clinical for deep GA? Is usually a kid who doesn't have JRA and doesn't have rheumatic fever, who develops these deep lumps, and they look just like rheumatoid nodules. So the other name for deep GA is pseudo-rheumatoid nodule, right? Because they look just like the rheumatoid nodules, and rheumatoid nodules you see in RA, but you also see in rheumatic fever, and you can also see them caused by methotrexate. So there is methotrexate-induced nodulosis, where you get this accelerated, these nodules that pop up when you're on methotrexate, usually in RA patients, and those are indistinguishable from their idiopathic rheumatoid nodules often. Just important to recognize because it is one of the rare complications of...
Is that any form or is that only like sub-Q methotrexate?
That is any form of methotrexate can do that. Here. Okay, Kendall.
So this looks like a shave of some sort. We have some lighter pink staining material down below. So that's potentially necrosis.
Yeah, and that actually was brilliant and well done. So it's just not staining as intensely as fibrin. You see a little fibrin around the edge here, but the center is very dull pink, not that intense pink of fibrin. So it is necrosis. In fact, it's caseous necrosis, right? So caseous necrosis, and surrounding that caseous necrosis
are giant cells and a little bit of granuloma surrounding that. So I'd be concerned about TB, but it could also be LMFD.
LMDF, you are correct. Very nicely done, and that's basically your top differential. So something infectious, with TB being at the top, you know, your classic caseating granulomatous disease is tuberculosis. And then LMDF, lupus miliaris disseminatus faciae, or you can say acne agmenata because it's a little easier, is a form of caseating rosacea where you have very discrete papules all over the face, and histologically they look just like miliary tuberculosis. So what was the old name for tuberculosis of the face?
Lupus vulgaris.
Lupus vulgaris, which meant common lupus, right? Lupus erythematosus came later. That was when it was more erythematous and different, but also chewed up your central face like a wolf had mauled you, right? But original lupus vulgaris meant TB of the face, and it was very common. So it was common lupus, lupus vulgaris. So back in a day where tuberculosis was common, and you saw multiple caseating granulomas on the face that were miliary, if you wanted to name the condition disseminated miliary TB of the face, what would you call it? Lupus miliaris disseminatus faciae. Right? So at the time they assumed it was disseminated miliary TB of the face. They were wrong. It's a form of caseating rosacea, but the name has stuck from what they originally thought it was. So LMDF literally means disseminated miliary TB of the face, lupus miliaris disseminatus faciae. And it looks just like disseminated miliary TB of the face, but it's caseating rosacea. Well done. Okay.
So, infiltrate down deeper.
So infiltrate down deeper, and it is all histiocytic. And the way you know it's histiocytic is if you go on higher power, there's cytoplasm, and there's no collagen between the cytoplasm. So it's cell upon cell, cytoplasm upon cytoplasm. That's what defines histiocytic granuloma. Right? And the pattern of that is linear, palisaded, or interstitial trapping collagen.
Interstitial trapping collagen.
So it's interstitial trapping collagen, and this patient came in because he thought he had been infested with a parasite. He'd been traveling, and now he has this thing that looks like a worm has crawled under his skin on his lateral thorax. And you see on biopsy interstitial granulomatous dermatitis. So what's the name of the condition?
Interstitial granulomatous dermatitis.
Yeah, IGD, right? So that's what IGD is. That's a classic presentation of IGD.
So you have some central caseous and corrosive.
Yeah, so that one looks kind of caseous, right?
You can see that, I think, sometimes in circling.
And
makes you think more of the differential we did is coming up here.
we're actually going to go a little higher, though, because I agree with you. At scan, it looked caseous.
There's mucin in there.
When you go higher, the reason it looks caseous is that you have equal amounts of fibrin and mucin, making it look amphiphilic. So what would be a deep palisading granuloma with equal amounts of fibrin and mucin?
Deep GA.
Deep GA. And this one you can just call deep GA. If it really looks like a rheumatoid nodule, it still could be pseudo-rheumatoid nodule, deep GA. But this one, you know, rheumatoid nodule can't do the mucin. So this one you know is deep GA. Just by looking at it.
So just based on the architecture, it's likely, and the chapter, Verruciform xanthoma, but you get the little pink V's and the kind of little paler appearance to the dermal papilla.
Yeah, so that's exactly what it is. It's Verruciform xanthoma. 99% of Verruciform xanthomas occur where?
In the mouth.
Mouth or genitalia. Those are your two, that's the majority. The ones in the mouth are thought to be a papilloma of some sort. The ones in the genitalia are usually thought to be venereal warts clinically. There is no association of HPV with these. And histologically, what you get is a bump. There's usually hypergranulosis and hyperkeratosis because it looks warty. Your papillae are expanded with kind of amphiphilic, pale grayish pink stuff. And then you have the V's with neutrophils, and those V's are pointing down like arrows. Hey buddy, look down in the papillary dermis, pointing you to the xanthoma cells, and the xanthoma cells are usually subtle. So unless you catch it on architecture, you're not going to think to look.
Dr. Elston, I have a quick question about the big test at the end. Regarding the deep GA and rheumatoid nodule.
You're talking about the review exam we will have soon because you guys are building them into the schedule, right?
We can make it that, yes.
Yes.
So you can, if you see mucin, that cannot be rheumatoid nodule.
That is correct.
But if you have deep GA, you can have a mucinless deep GA.
That is correct.
So if you had that, it would not be reasonable to have both answer choices, rheumatoid nodule and deep GA.
Everything that you just said is correct. So if it is a deep palisading granuloma with both fibrin and mucin, you know it's GA.
Mm-hmm.
It's deep GA. If it has only the fibrin, it could be rheumatoid nodule
so you can't be
or deep GA, and so it would not be fair to have both choices.
Great.
But either choice would be fine.
Thank you.
So we have a fragmented specimen that looks like it has granulomatous inflammation in it.
Yep.
Some of them depends on your definition of naked for some of them, but there's not a ton of mononuclear infiltrate around some of them. That one looks well formed. The other piece looked a little more edematous, that piece.
Yep.
And made me wonder more about something infectious.
And so, I mean, that's all exactly where you would go. What if I told you this was from the lower buccal mucosa on the chin area? So buccal mucosa sort of lateral to the, actually kind of lower lip on the buccal side, about halfway between the midline and angle of your jaw. Yeah, like a mucocele. Exactly. So, mucoceles, sometimes you see the mucin, sometimes you just see the granuloma. Location history is kind of key. So for the clinicians, mucoceles, so take your tongue, stick it right in the middle of your bottom lip, and you don't feel a whole lot. Now feel about, a third of the way over on your lip. Right there, and right there. And it feels like tapioca. Those are all of your minor salivary glands. How many of you have done minor salivary gland biopsy at this point? Nobody's done? Wow. Justin's the only one who's done. That is one of your skill sets. How many of you have done temporal artery biopsy at this point? None.
We're still trying to get nails.
Okay. I mean, those are both standard, that's scope of practice for derm, both of those. So try to seek out opportunities.
So does your temple hurt?
Does my temple hurt? Yeah, actually, I had a little scotoma and a chronic headache. So, temporal artery, you're just Dopplering and, taking a 2 centimeter segment. The minor salivary gland, the key is you are injecting on the mucosal side. To do anesthesia, and then you are going in with your iris scissors and you are spreading tissue, never snipping, and then you are squeezing, and out pop these little round looking pearls that look like little lumps of fat, but they're kind of firm, and those are your minor salivary glands, and you just pop them out and put them in a bottle. And we do that looking for Sjogren's, and we do it looking for amyloid. So why do you never snip?
Because you can't feel part of your lip still.
That is correct. So you have your the mental foramen is where your sensory nerve comes up for your lower lip. If you've ever been to the dentist and had a nerve block, you can leave someone permanently numb like that if you snip that nerve. So you never snip in that location. Okay. Let's see what else we need to do here. So we've got that. We've got this one. Okay, that's a mucocele with more mucin in it, and you have mucophages around the edge. So this would be a more typical look for a mucocele. Lots of mucophage, palisaded granuloma, and pools of mucin in the center. And if you see the minor salivary gland sitting there, that's big hint. Similar appearance on an eyelid would be chalazion. Chalazion, chalazion, I think you can say it both ways. Let's see what else we got to do here. In the time we have. Okay, how about this guy?
So, Palisaded, I don't know if that's fibrin or actual case hystochrosis, but...
So does it appear more or less intense than the surrounding dermis? More intense, so it's likely fibrin. Right. So Palisaded granuloma around fibrin, so you were thinking?
Well, it would be either deep GA.
Yeah, either rheumatoid nodule or deep GA. I see a little bluish stuff in there, so you'd want to see, you can do a mucin stain. In this case, you'd find it's not mucin, it's a little bit of fibrinogen, giving you a bluish hue. That's a pitfall, because fibrinogen is blue, mucin is blue, so your mucin stain can be helpful.
Xanthogranuloma.
So you might think of a xanthogranuloma. In a xanthogranuloma, you have granulomas and you get multinucleate giant cells. And where do those giant cells tend to form in the granuloma?
Looks like they're more at the outer.
Yeah, at the periphery is where they tend to be, and they lipidize. In this case, it looks a little different. I don't see two-ton giant cells so much. I see a lot of hemosiderosis, and they are more foreign body type giant cell rather than wreath type giant cell. And this actually could be a soft tissue giant cell granuloma, like a giant cell granuloma of tendon sheath. When you see it in deep soft tissue, it's called pigmented villonodular tenosynovitis.
That's what, yeah. That was
But you are in the right differential. Let's see. There are some other entities we need to hit here. Grab one of those other boxes, because we're seeing lots of similar stuff here, and we need to pick up some other entities.
There's one in a chapter called Lipidus histio.
Ooh, man,
Just labeled differently. I don't know if that one's going to be.
Okay, that's good. That will be a good thing to do. Okay, we're actually doing better here in terms of picking out some good things. You guys saw a good necrobiotic xanthogranuloma in the first session. Good NXG where they make nice X's, red X's, advertising their identity as an NXG. Okay, very good. Let's do this one.
Sure.
So you have a pretty dense infiltrate here. Appears to be more palisading, histiocytic.
So it's definitely granulomatous. Tell me about the cytoplasm of the granulomas. Is it uniform?
They look sort of two-toned.
They look two-toned. So tell me about two-tone cytoplasm in the histiocytic world.
It's something I associate with reticular histiocytic granulomas.
So reticular histiocytic granuloma when solitary, when multiple multicentric reticular histiocytosis. So what associations are there usually with a solitary reticular histiocytic granuloma?
Zero.
Nothing, yeah. Whereas with the multicentric ones,
destructive arthritis.
And malignancy. And malignancy is probably 20-25% that are perineoplastic. So how about the same kind of cytology with the two-tone cytoplasm in the melanocytic world?
I don't know, like a spitz.
Like spits, exactly. That is exactly right.
I can't say
Let's do this one.
So there's some giant cells.
Yeah, so there's some granuloma.
I think this is just JXG, but it's more, are we
is your epidermis normal?
No, so LCHE maybe.
So LCH, if you have histiocytic with epidermotropism of histiocytes, these look more like lymphs, just black circles. and you have some interface dermatitis. So I see interface dermatitis with limbs. My dermis looks kind of busy. I have granulomas.
So it's palisading language. Probably looking at PGMD. I don't know, sir.
So anyone put together a busy dermis? First off, let's just look at the epidermis. Busy dermis, interface dermatitis. Put those together. What do you think of? Syphilis. Can syphilis produce granulomas? Absolutely. Those are gummas, right? Gummas are granulomatous syphilis. So this is granulomatous syphilis. Granulomatous syphilis. Often you still have the hint of the busy dermis and the interface dermatitis, pointing towards syphilis. Okay. That doesn't belong in this chapter, but since we're here, what is that?
It looks like a. First, I thought maybe a basal cell, but.
So if it's a basal cell, it would be infundibulocystic, BCC, pink strands, blue buds, horn cysts. This one's probably more like basaloid follicular hamartoma, because it looks sort of trichoadenoma-like here. Does not belong in that chapter. Okay. So that one's probably too small by us. Let's skip that one and let us go to this one. Okay, how about this one instead, Iris?
Okay, so there are giant cells, granuloma.
There are giant cells, and the giant cells tend to be wreath-like, often with lipid at the periphery of the wreath.
So is it a xanthogranuloma?
So xanthogranuloma would be the most likely for that.
Histiocytes in the dermis.
So histiocytes in the dermis, and what's their pattern?
Kind of interstitial between
Interstitial and palisaded. So normally you would think of GA, but when you look at the stuff in the middle, instead of being granular like mucin, it's a little feathery.
Feathery, so this gout.
Like gout, or what else? What looks kind of similar to gout that has...
Pseudo-gout.
You are correct, although that has no cutaneous manifestation. But when you tap a knee, it looks similar. But these are xanthoma cells.
Eruptive xanthoma.
So it would be an eruptive xanthoma. And that is really important because you will look at eruptive xanthoma and you will think gout. Because you're seeing feathery crystals, palisaded granuloma. The hint is the xanthoma cells in the periphery. Right? So, eruptive xanthoma. And eruptive xanthoma tends to go with what types of hyperlipoproteinemia?
1, 4, and 5.
Mainly one. Well, you can see it in 4. 1, 5, and 3 are your most common. The broad beta type is a big one for eruptive xanthomas as well. Okay, let's do this one.
Okay, so we've got pretty thin shave here. Looks like there's a lot of foam cells.
Yeah, foam cells spread out in like a band. Tell me about the size of the hair follicles.
Vellus hairs.
Yeah.
I think we're probably on an eyelid.
So probably on an eyelid. So what would give you?
I would call this Xanthelasma.
Xanthelasma. Very good. That is absolutely correct. Okay, So we obviously have a deep nodule that was biopsied, and you have sheets of amphiphilic histiocytes, and you have nodules of black lymphocytes. And then when you look at those sheets of amphiphilic histiocytes, there are gray cells with a little bit of cytoplasm superimposed on them. So this is
Rosai-Dorfman?
Rosai-Dorfman, you are correct. What confirmatory stain would you get?
S100?
S100. That's your easiest. They're usually strongly S100 positive. So Rosai-Dorfman, you get sheets of histiocytes, nodular lymphoid aggregates, and then superimposed on the histiocytes, there are lots of cells, and there are two things. One is they're gray rather than being black, tells you they're not lymphs, and there are no pycnotic cells anywhere. So none of this is phagocytosis. That's what tells you it's erypolysis rather than phagocytosis. So the difference is who's the aggressor. In phagocytosis, it's the histiocyte engulfing and digesting the plasma cell. In erypolysis, it's the plasma cell that's moving through the histiocyte. Okay, so no plasma cells being digested, no pycnotic nuclei, sheets of amphiphilic histiocytes, nodules of lymphocytes, plasma cells that are gray, not black, superimposed on the histiocytes, no pycnosis, Rosai-Dorfman. So it's obviously ulcerated, right?
Mm-hmm. So a lot of granulomas in here. Looks like there's a lot of areas of palisading as well. Giant cells.
And what kind of giant cell?
They look like the wreath shape.
Wreath shape. Other name for wreath shape is Langhans giant cell. So foreign body giant cell, randomly distributed nuclei. Langhans wreath, Teuton wreath with lipid on the outside of the wreath. Osteoclast-like scalloped borders, randomly distributed nuclei, darker pink cytoplasm. So those are your different types. So lots of Langhans type giant cells.
Yeah, a lot of them are on the periphery. So
and a lot of them are on the periphery, not so much in the center, which goes with
an XG, xanthogranuloma.
Xanthogranuloma. What's missing for necrobiotic xanthogranuloma?
The necrobiosis.
The necrobiosis, right? Which in NXG would tend to form X's of red, advertising itself as an NXG. Importance of NXG, if it were associated, would be what?
Like a kappa gammopathy.
Kappa gammopathy, absolutely. And in a just an XG in a kid. Any associations to that?
NF1.
So NF1, and if you have NF1 and xanthogranulomas, what else might you have?
CNS or eye abnormalities.
So you may have eye, ocular xanthogranulomas, cardiac xanthogranulomas, things, but the other really important association,
MO.
exactly, is leukemia in kids. So NF has an increased risk of leukemia in kids. Xanthogranuloma has an increased risk of leukemia. If you get a double hit and you have NF with xanthogranuloma, your risk of leukemia is pretty high in that child. And, we derms do make the diagnosis of leukemia by cafe au lait macules with xanthogranuloma in kids.
Dr. Elston, when you see multiple JXGs, do you check the eyes always, or does it have to be
so multiple JXGs? First off, you check for any sign of Langerhans cell histiocytosis. So you look for diabetes insipidus, splenomegaly, anything like that. You get a CBC, make sure that their counts aren't down. But then it is probably a good idea to get an eye exam, have someone listen to their heart, just see if they're healthy. Okay, how about here?
So we have like a pretty good diffuse infiltrate of lymphocytes with little lymphoid aggregates. We also have some trapping collagen. Got some granulomas in there as well. Have a lot of foam cells potentially. They seem kind of bubbly, and plasma cells.
And any of those plasma cells pycnotic?
Maybe.
I don't see any, really. So I have sheets of histiocytes, question of whether it's foamy or just granular cytoplasm, but I definitely have lymphoid aggregates, and I have plasma cells superimposed on those histiocytes.
So we're thinking like a Rosai-Dorfman?
Thinking like a Rosai-Dorfman. Very good.
Some foam cells in there.
So foam cells, other name for foam cells? Xanthoma cells. So xanthoma cells are foam cells. And so, do you see any multinucleate cells at all? Any wreath type?
I'm not seeing any.
Not really.
No.
So there's nothing for xanthogranuloma.
More just a xanthoma.
More like just a xanthoma. So then the question is, what kind of xanthoma? A tuberous xanthoma has a lot of fibrin and few foam cells. This one is all over the patient's flexures, so sides of the neck, antecubital fossa.
And the patient kind of talks like this with a raspy voice. So if I talk like this and I have flexural xanthomas, what do I have?
A problem.
Okay, so anybody? So you've got vocal cord involvement, mucosal involvement involving the vocal cords, as well as flexural involvement, Xanthoma disseminatum. And what is the most common systemic manifestation of Xanthoma disseminatum? Or diabetes insipidus would probably be higher. So DI. So Xanthoma disseminatum looks like a limited form of histiocytosis X, almost. They're not CD1A positive, but you do get diabetes insipidus with it. And it's flexures and vocal cords, classically. Okay, we got to stop right there. Let's just, I'm going to flip up to just to walk you through them. So this one, first off, you have acanthosis reminiscent of dermatofibroma. And then you have these pyramidal histiocytes that are factor 13A positive. That would be an epithelioid histiocytoma, right? Kind of variant of dermatofibroma with pyramidal histiocytes. And then here you have granuloma, kind of deep, pockets, clusters of eosinophils within that granuloma. That's a big hint towards histiocytosis X. So that's one of the things that would make you look for CD1A positivity. Okay. Granuloma's big chapter. Spend some time going through them on your own, because there's a lot in that chapter.